if you accept that the capillary glycocalyx is a real thing and that the Starling principle is fatally flawed, then you're going to have a real problem with the concept of colloid-based fluid resuscitation. For many decades, the argument for using large molecular weight compounds emulsing crystalloids as a way of volume-sparing resuscitation versus the use of crystalloids alone was a major topic of medical conferences and journals. I believe that the topic is currently closed in favor of crystalloids for reasons that I will outline in the next two tutorials. But what of albumin? Tutorial 11, Albumin and Colloids. Previously we discussed Starling's hypothesis and why it is problematic, the structure of the microcirculation, the capillary glycocalyx, transcapillary fluid movement and albumin leak, and lymphatic flow. This time I will discuss albumin's role in physiology, hypoalbuminemia, and albumin transfusion and colloids. Let's start with a scenario. You are rounding in the ICU and Jackie is 42 and septic. She's hypotensive with a blood pressure of 84/48. Her serum albumin is 28 grams per litre, and you are instructed to administer 20% albumin to her until the blood albumin level is greater than 40 grams per litre. The purpose of this is to restore colloid oncotic pressure. Is this a valid idea? Well, let's start with some science. This is a graphical representation of an albumin particle, and it's a single polypeptide made up of 585 amino acids. Its molecular weight is 66,500 Daltons or 66.5 kilodaltons. What's a kilodalton? Well, this is a unit of measurement to look at the size of large molecules. And 1 Dalton is 1 gram divided by a mole. For example, carbon has an atomic weight of 12.011 and a molar mass of 12.011 grams per mole. So carbon is 12 Daltons, essentially. And 1 Dalton is 1/12 of a carbon atom. So when you think about it, 66,000 is a rather large particle with respect to albumin. Now, albumin is made in the liver and it's manufactured at a rate of about 9 to 12 grams per day. The rate of production of albumin is controlled by changes in osmotic pressure and osmolality of the extravascular perihepatic space. And 1 gram of albumin holds 18 mils of water in the interstitial gel. Albumin is carried through the endothelial cell by transalveolation. Remember those pathways we discussed in the last tutorial. It may also be carried through the cleft, and its transcapillary escape is about 5% per hour or 10 grams per hour if the body albumin is normal. Now, in systemic inflammatory response syndrome, in inflammatory conditions, the escape rate increases by 300%. So that's like 30 grams per hour, most through the paracellular route. So it leaks between the endothelial cells. Albumin has a whole bunch of physiologic roles. Now this is a bit boring, but you sort of need to know it. It binds to various other particles, some very important drugs, benzodiazepines, particularly midazolam, anesthetic agents like thiopental, thiopentone, non-steroidals, warfarin, tacrolimus, digitalis, furosemide, some penicillins, thyroxine, all very important agents. It also binds calcium and magnesium. It's involved in free radical scavenging. It's an important component of acid-base chemistry, as we'll talk about later on. And it's involved in coagulation to a greater or lesser extent and has impacts on vascular permeability. It also acts as an antioxidant. It's involved in free radical scavenging and it's believed to be a detoxification particle. And of course, it may protect the glycocalyx and promote the normal coagulation response. If you look at the distribution of albumin, and in this cartoon, we have production at 13 grams per day. There is 118 grams in the intravascular space. The transcapillary escape rate is about 4.5% per day. And in the extravascular space, there is roughly 242 grams, of which 177 is exchangeable and about 65 grams is stuck, so it doesn't move around between the interstitial space and the vascular space. We lose about 13.6 grams of albumin per day, which essentially is the same as the amount we manufacture in our livers. Just a point to make here at an early stage that we will come back to later on in the course is the charge attributable to albumin. The charge for albumin is essentially the albumin in grams per litre multiplied by 0.123 times the pH minus 0.631. So if albumin is 42 grams per litre and the pH is 7.4, the attributable charge is 42 times 0.123 times 7.4 minus 0.631, and that works out at 11 milliequivalents per litre. If the albumin is lower, for example, 30 grams per litre with the same pH, the attributable charge works out at 30 times 0.28, which is 8.4 milliequivalents per litre. This is very important with when you're thinking about the anion gap and when you're calculating it out doing acid-base conundrums, because a big component of the anion gap is that charge that is attributable to albumin. Now, there's an easy way to calculate this without doing that whole calculation. The plasma albumin in grams per litre times 0.25 is the attributable charge. So if the albumin is 30 grams per litre, the charge is 7.5 milliequivalents per litre. So fairly easy rule of thumb. Now, here we have whole blood, and whole blood, of course, contains hematocrit of about 45% and plasma, that's 55%. The plasma water is 93%, and that contains electrolytes and solids. And if you were to look at the true electrolyte distribution across between the blood water and the interstitium, you'll notice there is slightly higher charge carried by albumin in the blood versus in the interstitium, because there is a relatively higher ratio of albumin in blood versus the interstitium. And a result of that is that the electrolyte content is a little bit different than you might imagine when you take a blood sample. When we take a blood sample, it's all equalized from interstitial fluid versus the actual intravascular fluid. And indeed, if you actually look at the content, there's slightly more sodium in the blood water than there is in the interstitium. And there's slightly more chloride in the interstitium than there is in the blood water. And the reason for this is the Gibbs-Donnan effect, is that the albumin in the bloodstream holds on to slightly more water, and because of its negative charge, it equalizes with slightly higher sodium level than in the interstitial space. But of course, when we do blood samples, we don't measure one or the other. Let's revisit the endothelium and the glycocalyx. The glycocalyx regulates endothelial function. It regulates vascular permeability and is involved with blood rheology and viscosity. Red cells are repulsed from the endothelium by the glycocalyx. It's also involved with inflammation, coagulation, and fibrosis. Remember this picture here that we had our glycocalyx and our subglycocalyx layer, the SGL. There is no albumin in the SGL and minimal amounts of it in the interstitium due to the washout effects of fluid that is being continuously filtered. In the traditional Starling model, when hyperoncotic, that's 20% albumin, for example, albumin is administered to the patient, the oncotic pressure difference between the inside of the capillary and the interstitium results in water being drawn back along this gradient from the interstitium back into the capillary lumen on the venous side of the microcirculation. So that higher oncotic pressure within the lumen is the draw for water to come back in. However, if you look at the newer model, there is no gradient between the lumen and the interstitium, but only between the capillary glycocalyx and the lumen. Consequently, If hyperoncotic albumin is administered, it is far more likely that water is drawn from the glycocalyx itself, remembering that the glycocalyx is a hydrated gel, than from the interstitial space. Now, when there is inflammation, this impacts the glycocalyx. You can see here there's an inflammatory injury, and this damages the glycocalyx and the endothelium, and it makes the endothelial porous to protein-rich fluid that extravasates out. So there's redistributive hypoalbuminemia that we see in capillary leak syndrome. If you look at albumin over disease states, albumin does not decrease in starvation until a very late stage. The visceral protein is maintained at the expense of muscular protein. Albumin is also a poor marker of liver dysfunction, and it may be lost in kidney disease, particularly nephrotic syndrome. So when we think about patients who have hypoalbuminemia, we really need to look at their clinical situation when you're considering whether it would be appropriate to actually administer albumin to them. So I've divided them into 4 different types of patient that we can have a discussion about. The first here is Brian. He's 28. He was in a car crash. He's major injuries and he's lost a lot of blood. The second is Mildred. She's 52. She's had major surgery and she has postoperative hypotension and oliguria. We have Richard, who's 65, who has cirrhosis, he has ascites, and he needs to have paracentesis. And finally, we have Jackie, who we've met earlier on in this talk, who is septic and hypotensive. Now, in terms of Brian, who's bleeding after the MVC, modern resuscitation strategy is damage control, so we principally give blood products to these patients. And there is no question that there is a total body albumin deficiency. So it's not unreasonable to use albumin as part of the resuscitation to minimize crystalloid overload, but be aware that there is lots and lots of albumin in pooled plasma, so it isn't necessary, but it is something that you might consider. What about Mildred, who's had major surgery, who's had an epidural, who's hypotensive and oliguric post-op? The reason why she's hypotensive is due to anesthesia and surgery-induced vasoplegia. Her total body albumin and colloid and colic pressure, unless she's lost loads of blood, is likely normal. So there's no indication for albumin transfusion. And if you wanted to give some kind of colloid, and we can get back to that, inexpensive synthetic colloids may or may not be of benefit in this setting by just bringing up the blood pressure for a short period of time. Richard, who has cirrhosis and needs paracentesis, has massive ascites. So the purpose of doing the paracentesis is to release this pressure caused by the ascites, and acidic fluid is really protein rich. So if you take a lot of acidic fluid off, you are depleting his whole body's supply of albumin, and the patient is at risk for developing a thing called post-paracentesis syndrome. And this involves rapid fluid shift to the extravascular space, vasoplegia, reduced renal blood flow that may precipitate acute kidney injury. There may be hyponatremia with seizures, and all of this may result in increased mortality. So and on top of this, of course, the liver's synthetic function may be reduced because the liver is badly damaged by cirrhosis. So it seems quite reasonable to transfuse albumin in this setting. So for paracentesis, where usually 8 to 10 grams of albumin are removed, administration of albumin-rich fluid to resuscitate the patient seems to improve outcomes, and there is strong data for this, although the mechanism is unclear to support albumin administration in that setting, but also when there is spontaneous bacterial peritonitis in this type of patient, when you also give antibiotics. But it's important to also understand that just because a patient has cirrhosis and is in hospital, they don't necessarily need or should be given albumin. And this is the results of a randomized trial from 2021 in the New England Journal, where patients with an albumin of less than 30 who had cirrhosis, who happened to be in the hospital with as a consequence of their liver disease, they were given 20% albumin therapy to push the albumin over 30 grams per litre up to 14 days. And they looked at new infection, renal dysfunction, and death before day 15. Median dose of albumin was 200 grams, that's 10 bottles of 20%. And the results of this study was no difference in outcomes. There was no benefit from targeted albumin therapy. And indeed, there were more severe or life-threatening adverse events occurring in the albumin group than in the standard care group. So if you're going to be giving albumin to cirrhotic patients, it's really for spontaneous bacterial peritonitis and for paracentesis, not just because they're in the hospital with decompensated liver disease. Well, what about Jackie? Jackie is septic shock. She's hypotensive. She's hypoalbuminemic. Should we be giving Jackie albumin to restore her plasma levels? Firstly, there is a really strong correlation between low plasma albumin and adverse outcomes in critical care. The lower the albumin, the worse patients seem to do. Now, there are many, many reasons for this, and it's not necessarily the low albumin that results in people dying. They die of multi-organ failure, usually from sepsis or some other injury. So when you look at Jackie's albumin, 28 grams per litre, it's fairly low, and her albumin is low for three reasons. First of all, she's likely been well resuscitated with crystalloids, so she's hemodiluted. Also, her, as I've shown you earlier on, her capillaries are damaged and she's leaking albumin into the interstitium. So, you know, the interstitial albumin level may be higher than is normal and the plasma albumin level lower. And then, of course, the liver in acute stress states reprioritizes its production facility. So it starts making globulins and other inflammatory proteins rather than albumin in those states. So essentially the production of albumin is turned off. Also, the reason why people think about albumin is they're worried about this concept of colloid oncotic pressure. And that if colloid oncotic pressure is low, they believe that it makes the plasma water more likely to leak out into the interstitium than if the colloid oncotic pressure was normal. And they ascribe most of the colloid oncotic pressure to albumin. But it's been well demonstrated that in critical illness, the plasma albumin falls, but the colloid oncotic pressure remains close to normal levels because of all the other proteins that are made. And that's because of the concept of hepatic prioritization. And this is just one study that showed clear evidence that serum albumin falls, but colloid oncotic pressure, colloid osmotic pressure, does not seem to change in critical illness. So the normal colloid oncotic pressure is 20 to 25, and it is the same in survivors and non-survivors. Well, what about Jackie, who's hypoalbuminemic? What is the purpose of giving her albumin? Well, presumably as a plasma volume expander. It's colloid, it should stay in the bloodstream, it should improve overall tissue blood flow, it should reduce the need for crystalloid, it may reduce the need for giving her other agents that vasoconstrictor like norepinephrine or epinephrine, and it may improve flow to the kidneys to prevent them from failing. It also will restore plasma albumin levels, and you know, albumin has lots of other biological functions, including the stuff that I mentioned earlier on. And finally, it's quite commonly used to help remove fluid. So the idea is that if you want to de-resuscitate an edematous patient, you give the patient albumin and then you give them furosemide, for example. And the idea is the albumin somehow or other sucks fluid back into the bloodstream, and then the furosemide diureses that off as the fluid goes through the glomerulus in the kidney. However, to date, no high-quality clinical trials have established the therapeutic benefit of albumin transfusion. The most important trial was the Albios trial that was done in 2014, where they basically tried to normalize plasma albumin in patients with sepsis and septic shock, and they were not able to show any benefit from normalizing plasma albumin concentration. Of course, albumin is not the only colloid. Albumin, by the way, comes in 5% and 25% or 20% solutions, the latter known as hyperoncotic albumin. But there are other colloids out there, such as succinylated gelatins, such as Hemosil, Gellofusion, Geloplasma, are most commonly available in Europe. They're not available in the United States. Hydroxyethyl starches that come from maize or from potatoes, and dextrans. And the colloid concept is very simple. You take a crystalloid solution such as isotonic saline or compound sodium lactate, that would be lactated ringers, and then you essentially emulse a bunch of thick, large particles that are sized between 50 and 150 kilodaltons, and you suspend them in the solution. And the idea is that when we look back at the distribution of fluids in the body, and remember that dextrose spreads across the entire body water, the colloid essentially stays completely in the bloodstream, that it stays in that intravascular space, and by increasing the colloid osmotic pressure, it holds water in the bloodstream and stops fluid from extravasating and causing tissue edema. So when are colloids used in anesthesia and critical care? Well, sometimes they're used in the operating room, sometimes used obviously in the ED or the ICU. In the operating room, they're usually used to treat vasoplegia, where patients have general and neuraxial anesthesia. The patient is a bit vasoplegic, and these fluids are given just to fill up the intravascular volume for a short period of time. And in the belief that somehow or other they either stay there or they actually suck fluid back from the interstitium. And they're also sometimes used for blood loss and surgery. In the ICU, they've been traditionally used for sepsis and neurogenic shock for vasoplegia, in patients with reduced ejection fraction and cardiogenic shock, and of course during blood loss for trauma following surgery or surgical illness. And the main question about hypotension in any of these settings is whether or not capillary leak is actually present. Returning to this whole concept, here we have our microcirculation, and it gets injured, and as a result of that injury, all kinds of fluid starts to leak out from the capillary network, from the microcirculation into the interstitium, and it contains a fair amount of albumin. The conventional wisdom about giving intravenous albumin solution is that it essentially is injected into the body, and then it holds oncotic pressure, but some of it will extravasate just like your own albumin. However, there is a counter argument that it may actually restore the damaged glycocalyx. So instead of pouring out through these holes in the endothelium, the albumin may actually start binding up to the glycocalyx. And even if the holes in the walls of the endothelium may look like they're very large, by albumin binding to the glycocalyx, it may actually help to restore it. Now, I do want to point out that this is really only a hypothesis, and of course, recovery of the glycocalyx may be consequence of another constituent of the hypertonic albumin solution, and plasma transfusion itself seems to be actually better than just giving albumin. But there is a hypothesis out there that albumin or plasma is in some way restorative to leaky capillaries. The other question, of course, is do colloids actually suck fluid back from the interstitium and minimize tissue edema during resuscitation? So here is the kind of concept that many have believed these colloids do. Here, these are hydroxyethyl starch particles, and you can see here they lodge some of them at least lodge in those damaged walls of the endothelium and the glycocalyx, and stop the rot, I suppose. It's like putting your finger in the dike and preventing liquid from leaking out. And because they're hyperoncotic, the idea is that fluid now moves back into the bloodstream from the interstitium. So there's no doubt that this happens, right? So there's no doubt that large molecular weight colloids plug to a certain extent leaky capillaries, and they do expand plasma volume by a quantity greater than that infused. But now I'm going to get into some really boring slides because I'm going to have to go through the literature on this. The colloid versus crystalloid question hinges essentially on one fact. Do colloids more rapidly reverse shock with lower volume? This is known as the colloid effect. There are many who believe that if you give, for example, 500 mils of colloid, the plasma will be expanded by at least 500 mils, more likely a litre, possibly even a litre and a half. So the colloid somehow or other desequesters fluid from the interstitial space. The idea then, of course, is there's less fluid accumulation, and this would somehow result in reduced organ failure. The problem with colloids, though, is that they have issues. Firstly, they are known, not all of them, but the majority of colloid fluids increase bleeding complications, and you get acquired and dilutional coagulopathy. There is tremendous evidence that colloids damage the kidneys. There's also an issue that they mobilize very slowly when the source is being controlled, and that may actually delay the diuretic phase and the restoration of body weight back to normal. And there is an issue with allergy and anaphylaxis. And what started the questions about colloids was, in fact, a study in the Cochrane collaboration on albumin many years ago in 1998, where it was suggested that giving human albumin solution in a variety of clinical scenarios actually increased patient risk. A few years later, this was in 2004, a group from Australia decided to see if this was in fact the case, and albumin was given to patients, either albumin or saline was given to patients during fluid resuscitation in ICUs. And this particular study showed really no evidence that albumin was harmful, but of course it didn't show any evidence that albumin was beneficial either. Now, there are other synthetic colloids, succinylated gelatins that I've already mentioned. They have a really short duration of action, but they seem to be relatively safe, and they don't seem to do much harm or much good either. Dextrans cause significant bleeding issues, and they are not used these days for plasma expansion. And then we have hydroxyethyl starches, and they were around for many years. The early hetastarches were very large molecular weight molecules. There was major issues of bleeding, and they almost certainly damaged the kidneys. And then we had the later tetrastarches that were kind of smaller molecular weight compounds. They were considered safer because of less coagulation. And then the studies started to arrive. The first one was the VICEP study that looked at 10% pentastarch versus lactated ringers. And they found that the patients who got the hydroxyethyl starch had a significantly higher rate of requiring dialysis. They had a higher rate of acute kidney injury. And the real killer for this particular agent was that the fluid requirement ratio was only 1.3 for lactated ringers to 1 for colloid. So the so-called plasma expansion effect of colloid was minimal at best. This was followed in 2012 by the 6S trial, the Scandinavian starch trial, that looked at 800 critically ill patients who had received either Ringer's acetate solution or hydroxyethyl starch, tetrastarch, that was in Ringer's acetate. And they followed the patients for 90 days. And it turned out that the patients who received hydroxyethyl starch had a significant increase in mortality. They also had a significant increase in the need for renal replacement therapy. Moreover, the volume of fluid administered to each group was not different. There was no colloid effect and no fluid sparing, totally consistent with the findings of the VICEP trial. There was no difference in time to shock reversal for any of the groups, so no so-called colloid benefit. And this, by the way, is consistent across a whole bunch of different studies that I've listed below. In all these studies, the maximum colloid effect was 1.4 to 1. And this really does not justify giving colloids or using them to somehow reduce the amount of fluid that you give patients regardless of what you believe. And these are the data that really killed off a synthetic colloid as something that was used in critical care. And you can see between 2007 and 2014 there was a dramatic reduction in the amount of synthetic colloids, but a dramatic increase in the amount of albumin, which still has not been proven to be clinically effective in critical care. Now, in the operating room, just so that you know, there are multiple small studies that suggest benefit for goal-directed resuscitation, but in most of these cases, the studies have compared colloid to crystalloid, not with the use of vasopressors, and really I can't find any evidence published anywhere, pretty much ever, for benefit of colloid resuscitation in critical illness. Just to finally just remind you of this Albios study, that was a study of 1,800 patients, and that trial did not show a benefit using albumin. And finally, there's the FEAST trial. And the FEAST trial was a study that set out to demonstrate the efficacy of fluid boluses for sepsis in African children. And in fact, it showed exactly the opposite. It showed that fluid boluses were associated with increased mortality in this patient cohort. A few other thoughts. Administration of albumin may, despite what I've already said, improve the efficiency of intermittent hemodialysis. It may enhance diuretic fluid removal temporarily in hypoalbuminemia, but there are big questions about it in patients with traumatic brain injury. It may worsen cerebral edema in traumatic brain injury, although this is clouded with the issue of whether the actual carrier fluid, particularly in the SAFE trial, may have been hypotonic with respect to plasma. I would have to conclude, though, that in critical illness, treatment with human albumin solution is based more on the belief that it works than on solid evidence. Let us return to this picture that I showed you in the previous tutorial. At very low volumes, such as in a state of dehydration or hypovolemia, the extracellular matrix is stuck down. It's sucked in to the endothelium. The interstitium is non-compliant, and albumin returns to the subcapillary space. So everything is just stuck in there. Filtration is minimal. As we will see in a later tutorial, that means that when one administers intravenous fluid in this state, most of it remains in the intravascular space, at least initially. Let's review this tutorial. In this tutorial, we covered the role of albumin in physiology. We looked at albumin in critical illness and capillary leak syndrome, the indications and questions regarding albumin transfusion, and the use of synthetic colloids in critical illness. Next time, I will discuss crystalloid infusions in normal people, the impact of anesthesia on the microcirculation, and fluid kinetics. Okay, that was a discussion on the use of human albumin solution in critical illness. It remains a popular therapy, and it may be of use in certain circumstances, but the evidence for critical illness is weak. Also, one has to be concerned that the actual molecule may be deformed or damaged during the refining process, thus limiting its biological effectiveness for example, delivering drugs. Other colloids currently have no role in critical illness.